Who's not muted, please mute. Okay, thank you. I'm gonna mute. Yes, everybody who is not presenting, please mute your microphones. Okay, just a minute. Mute. Okay. Okay, wonderful. So it's 11:30. And I would like to thank you everybody for joining us. So hello, good morning, good afternoon, or good evening, depending where you're located exactly on this globe. And my name is Helena Silman-Cohen, and I'm the education lead of the International Physical Therapist for Hospice, Palliative Care, Oncology, and HIV/AIDS, or for short, the IPT-HOPE. And I would like to welcome everybody. You and of course the speakers to the session. This webinar will be recorded. It's already recorded and uploaded to the IPT-HOPE website and will be available for everybody who is not here with us at this point, or if somebody would like to review it. So I'm very glad and honored to introduce our speakers for today. So we have Dr. Amy Dennett, who's a senior physiotherapist and research fellow at Eastern Health and La Trobe University in Melbourne, Australia, and holds a PhD focused on enhancing physical activity levels among cancer survivors through oncology rehabilitation, and who wrote, of course, and who established the exercise toolkit for cancer patients. So anybody who's not aware, please check it out. We have Dr. Emer Gwynn, who is an associate professor in cancer rehabilitation and survivorship at the Trinity St. James Cancer Institute from Dublin, Ireland. So hello. And we have also joining us today, Ilan Tausing, who leads the oncology physiotherapy team at Tel Aviv Sourasky Medical Center, Ichilov Hospital in Israel, who is specializing in tailored exercise programs for cancer patients. So I would like to thank you again, the speakers, for providing this presentation for us today. And I would like to hand this over to the speakers. So Amy, the webinar is all yours.
Thank you. So my apologies if there's a bit of a lag. My internet doesn't seem to be working very great this evening, but hopefully you can all see and hear everything appropriately. All right. So hopefully that screen has now come up for everyone. If you can just give me a little bit of a thumbs up. Yep, excellent. Thanks, Helena. So today I'm going to be presenting on a systematic review that we performed late last year about the status of oncology rehabilitation worldwide. So this hasn't been published yet, but provides some findings about where we're at in terms of exercise-based rehab specifically across the globe. And I'd just like to acknowledge my co-authors who helped put this paper together. So worldwide, does anyone have an idea of how many cancer survivors we have globally? If you do, pop it in the chat or have a guess. I'm going to give you, maybe I can give you a range. For those who think it's like 10 million or less, give me a thumbs up. If you think it's between 10 and 20 million, maybe you can put a heart. And if you think it's more than 20 million, I think there's like a party reaction or something like that. Okay, no, everyone's very quiet. Across the globe, we have 18 million cancer survivors globally. In Australia, we have just over 1 million cancer survivors that have been diagnosed in their lifetime, and about 500,000 that have been diagnosed within the last 5 years. So as cancer physios, we have a lot of people that we could potentially be helping out with exercise-based rehabilitation. And as many of you are all aware, that our patients suffer quite a myriad of issues, with fatigue being one of the #1 symptoms that people experience, that almost all cancer survivors will experience at some point in time. We also have issues like poor sleep, depression, reduced physical function, fitness, and many, many others. However, thankfully, in the last 10 years or so, but particularly in the last 6 years, we've had a real exponential growth in the awareness of the importance of oncology physiotherapy and oncology exercise in helping treat our patients and reduce their symptom burden and help them return to some kind of normality after their cancer diagnosis. So, as I hope that most of you are aware, but if you're not, in Australia, we have our Clinical Oncology Society of Australia released guidelines back in 2018 that every cancer survivor should be having a conversation with one of their oncology team about the importance of exercise, and then being recommended to exercise as part of their cancer treatment and be referred to an exercise specialist such as a physiotherapist. In 2019, these guidelines were given a little bit more specificity with an international roundtable statement, which was an update on some 2010 guidelines, which provides some more specific guidance that cancer survivors should be completing at least 3 lots of half an hour of aerobic exercise and twice a week strength exercise to reduce their symptoms associated with their disease. And in 2021, I think it was, or 2022, ASCO also released, so that's our American Oncology Society, released an exercise, diet and weight management guideline. But there's quite a number of guidelines across the world, and especially in a number of European nations in particular. And at our hospital, we've trialled a number of different cancer rehab exercise programs, and it really has changed a bit of the culture of how we talk about exercise and cancer with our patients and making it more of an expectation. However, in saying that, we're still not at that gold standard that everyone's having a conversation. So whilst the hospital that I work in and our healthcare service and healthcare system is quite well developed, we have universal healthcare, only a fraction of our patients will receive exercise-based rehab, especially in the public health setting. So I conducted a review probably back in 2015 that explored the landscape of exercise-based cancer rehabilitation in Australia. We've just updated that survey, which we're currently analysing the results now, 9 years later. But I wanted to have a look more broadly beyond the borders of Australia and the Pacific to look at the availability and content of exercise-based cancer rehab more broadly worldwide. So I know that there has been a number of surveys that have been conducted. So at the time of commencing this review, we knew that there'd been some surveys that had been conducted out of Ireland. Also, the UK had done a little bit of work, and America as well. So I knew that there was some more well-developed countries that had published surveys, but no one has systematically looked to see what other countries might have published data about their real-world cancer rehab programs. So for this review, we were particularly interested, obviously, in people with cancer and exercise-based cancer rehab programs. These cancer rehab programs had to be delivered in a real-world setting. We didn't want to include papers that were just research studies because they might not have been implemented in practice. And they were excluded if they specifically only evaluated the effect of a single program. So, for example, pre-post studies that might be looking at the feasibility of a program or randomized controlled trials. Our key outcome was just simply looking at what the program numbers were, but we also looked at program characteristics and also how that might have aligned with existing guidelines. So we were particularly interested in looking at surveys, mixed methods, or qualitative studies to find that information. We also documented any barriers or enablers to rehabilitation in those papers as well. So in terms of the results, we found over 1,800 papers with our initial search, which was reduced down to 38 papers. And we had a final library of 24 papers after 2 reviewers independently screening the titles and abstracts and looking at the full texts. We did use some quality appraisal criteria, but only 4 studies met all of these appraisal criteria, but most of them were able to meet at least half of them. So when we look at when programs were first being established, the first study of a nationwide survey of oncology rehab was published in 2005. And our first guidelines, for those of you who have worked in that space, have been around since about 2010. And the majority of studies have actually been produced since this time. So 22 papers of the 24 had been published since 2010. So our guidelines clearly have made a big impact in terms of the implementation of cancer rehab across the globe. So when we looked across the world, so there were over 2,000 oncology rehab programs that were identified. And this is a world map kind of identifying where these programs can be found. And as you can see, and probably not unexpectedly, our most wealthy and well-developed countries have the most cancer rehabilitation. Actually, the highest volume of programs was actually in Japan and Korea. These were more specific inpatient programs. And interestingly, one of the surveys was one of the first ones to have been published before our guidelines were even published. So the Japanese have actually been doing this for quite a long time. We also had quite a high number of programs in the UK and Germany, Netherlands. So up to 100 programs in those regions, as well as across the Americas. And as you can see, pretty much everywhere else in the world, as far as what's been published in research, there are not a lot of programs at all. So we should acknowledge that this relies on published research of surveys. So not to say that these countries don't have them at all, but they're not documented in academic literature. But I think it probably is reflective of the fact that there's less programs in these less developed nations. And when we look at geographical areas within countries, only a small proportion of papers reported programs that were even in regional and rural areas. So despite having an increase in telehealth, particularly since COVID, only 25% of studies did report programs in these regional and rural areas. And I think there was only 2 papers that reported use of telehealth at all, and they were both our Australian papers. But as I mentioned before, there has been evidence of increasing availability of exercise-based cancer rehab in some countries. So, for example, in Denmark, the availability of cancer rehab increased from 50% of the municipalities in 2012. They then introduced a policy mandating cancer rehabilitation, and this jumped up to 87% of municipalities in 2013. So having that mandated clinical pathway was really good at facilitating translation of that policy to practice. In Australia, we have had a clinical pathway for cancer rehab that's been implemented in some institutions as standard as part of post-operative management in people with lung cancer. And so therefore it was found in 63% of health services that were providing service for people with lung cancer. Also encouragingly, that in these surveys, there were documented plans for future cancer rehabilitation programs in 3 studies. So there was one study in Belgium, another in Japan, and another one in Australia that demonstrated that they were thinking about providing more cancer rehab programs. And overall, most of these programs were for adults. Only 4 studies looked at pediatric cancer rehabilitation as well. So a massive gap in that space as well. When we look at the content of programs, I'm a bit biased, but it was pleasing to see that physiotherapists typically led most of these programs. Well, not most, there were a lot of surveys that had education as formal parts of their cancer rehab program. So exercise, nutrition, and symptom management were the most common education topics. And these were particularly prevalent in studies that talked about rehabilitation programs. And unsurprisingly, our programs that are around in those studies that talked about barriers, they're typically underfunded. So a lot of these programs rely on donations and third-party funds in order to be able to deliver these programs. Very rarely are they funded by the institutions. Other barriers, which are well published in the broader literature, is lack of trained staff, lack of resources, including equipment and space, and lack of awareness about the benefits of exercise for cancer survivors, despite having all this research in the last few years. But in terms of facilitators, one study did report on this specifically. Having an exercise specialist that was embedded in the cancer team helped promote cancer rehabilitation. Having supportive links between hospital and community services was also good at helping encourage cancer survivors to be active. And also, what was interesting, programs that actually had good data collection around their programs and were translating this evidence directly into practice, that also seemed to be a facilitator as well. So I think that's a good point for anyone who is starting up a program, to be keeping good records of the benefits of your program to help facilitate growth. Other exercise characteristics of these programs, the majority of those published were face-to-face that we know of. In terms of group size, there was only a couple of papers that commented on this. So generally for adult programs, between 6 to 10 participants in a group. For pediatric programs, there was usually at least 3 participants in group rehab, with a staff ratio of anywhere between 1 to 4 participants for a therapist to up to 10 participants for a therapist. Generally, outpatient programs were run twice per week, and that's certainly reflective of our programs here in Australia. And inpatient programs were at least 5 or 6 times a week, but often daily as well. And in terms of our prehab programs, they were anywhere from 3 weeks to 6.5 weeks before having a procedure on average. And our rehab programs, which were more post-treatment or during treatment, were on average about 8 weeks long. Something that also featured as part of these programs was the inclusion of lymphedema exercise. All programs generally provided aerobic and resistance training and home exercise programs to encourage self-management. So when we think about the clinical implications of this systematic review, if you calculate how many people there are in the world and how many programs there are, for every 100,000 new cases of cancer diagnosed, just 11 programs are available. So, you know, this is a very broad statistic, but really goes to highlight that access is a huge problem for people with cancer. Really, the very privileged are the ones that are getting access to these programs, and they're usually in metropolitan and well-developed regions. So we really do need to focus on some of these underserved areas as well. We also have a lack of pediatric problems. Kids get cancer, and kids with cancer grow into adults with long-term cancer side effects. So this is another group that we should be concentrating on. And the guidelines in pediatric cancer are probably even newer than adult cancer, which might be why it lags a little bit behind. And something to consider with those programs is they need to be family-centered and child-centered. And there was a lack of telehealth reported, which could overcome some of these access issues. So hopefully in the future, we see more of these programs using telehealth. And as I mentioned before, encouragingly, guidelines have facilitated implementation of new programs to practice. Research translation is typically very slow. It does take up to 17 years. But as we found in this review, we had most of the studies published since 2010. That's only 14 years ago. And 9 studies were published since our most recent roundtable about 5-6 years ago. And in Denmark, that was a very clear example of the benefit of having policy and guidelines put into practice. So it's really important that when guidelines are published, we have good communication strategies to be able to put these into practice. And partly, I think what helped with our ACSM guidelines was that there was a really good communication strategy. There were resources made, there were infographics, which maybe has helped speed up some of that research translation. And finally, it's unclear how well our programs really align with guidelines. There was quite poor reporting of exercise characteristics in these papers, which does align with other research that has been done just more in trial settings. And potentially, you know, programs are only seen to be twice a week and only for 8 weeks when our guidelines say 12 weeks. But there's obviously in hospital-based settings in particular, a lot more funding restrictions that might limit the amount of resource that can be put into traditional supervised programs. So we need to be thinking about self-management and things like that to be able to meet exercise guidelines. So finally, I'll just plug, Helena also mentioned before about the Cancer Exercise Toolkit. If you haven't seen it before, there's a whole bunch of resources on here that give some guidance about how you might go about setting up a cancer rehab program. I am planning on updating this website this year because it has been a little while since it was updated. But yeah, jump on and have a look if you're thinking about setting up a program. I was going to play this video, but I think it's probably better to have more question time at the end. So I'll just go to our summary slide and then, yeah, we'll pass it over, I think, to, I'm not sure who was speaking next. So I'll pass it back to you, Helena.
Okay, wonderful. Thank you very much, Amy. Our next presenter will be Emma Gwynnan from Ireland. So you can go ahead, please.
Great.
And just a thing that I didn't mention it before, but we will like that everybody will ask the questions at the end of the webinar after all the presentations will complete. Thank you.
Great, thanks. Perfect, you can see this? Great, and hear me and all of that. Perfect. So thank you very much for the invitation to be part of this webinar this morning. My name is Emer Guinan and I am an Associate Professor in Cancer Rehabilitation and Survivorship at the Trinity St James's Cancer Institute in Dublin in Ireland, and I'm a physiotherapist by background as well. So I'm going to talk about the development and implementation of PERCS, which is, I suppose, an approach that we are trying to use to develop or to help us to expand the cancer rehabilitation and exercise services that we have nationally. So this comes from a background, I've been working in this space since, gosh, I think 2009 really. And this is the timeline of, I suppose, the research that has been conducted by our group. And I suppose we started very much in a space where research informed practice. We started with preliminary studies in 2018, 2011, some in prehab, some in rehab, identifying needs, qualitative work, exploring what could be done. And then we started to implement a number of trials. We were lucky to be involved in the recruiting site to the PREPARE randomized controlled trial, which was an international trial on preoperative inspiratory muscle training prior to esophagectomy. This really gave us insight into how to be part of trials, how trials run, and to give us the skills that we could set up some of our own. The Restore program, which you see down in the rehab, the rehab track there, has been one of our biggest pieces of work, and this has been focused on upper GI cancers, esophagectomy, gastrectomy cancers. And that allowed us to really go from needs assessment through to complex intervention development and through to definitive intervention development with Restore 2. At the same time, we've been running Pre-HIT, which again started around 2018, which is a prehab trial. And I suppose all of that research was building, and, you know, all the work that went into it. And then suddenly, about 10 years after we started, we started seeing some practice change. And two of the key moments, you know, shown here in this timeline. And the top one was in 2019, where a clinical specialist physiotherapist in cancer rehabilitation was appointed in St. James's Hospital to start building a service that worked with us on some of our trials, but also expanded, I suppose, the scope of what could be delivered to patients. And then in 2021, a clinical specialist physiotherapist in cancer rehabilitation was appointed, and that was the wonderful Gráinne Shiel. And I suppose this reflects the timeline and how we developed in one hospital in Ireland. But I suppose in particular, when Gráinne was appointed, we started to realise that in the rehab setting, Gráinne and, you know, her team that she's building cannot see everybody. We're a high volume centre. So how do we manage all the patients that are coming through Gráinne's rehabilitation service? She has an exercise rehabilitation service that, you know, tries to address impairments and tries to implement a pragmatic exercise program for people. And it's really from working with Gráinne and her service that we developed the PERCS program. And PERCS stands for Personalised Exercise Rehabilitation and Cancer Survivorship. So while we were progressing with our programs very much in St. James's Hospital, you know, nationally, we were starting to look at, well, how are our physiotherapists around the country feeling and coping, and what were they doing in terms of some of their programs? And we did this really nice piece of work with physiotherapists around experiences delivering cancer rehabilitation services, barriers to care, and service development needs. And I suppose some of the main themes that came out of that work were that, you know, there was a lack of awareness around the role of the physiotherapist. And of course, if other MTT members aren't aware of who we are and what we do, how do they know that they can refer to us? Funding and sustainability of services, big issue. And then external support, specialist training, you know, acute teams, multidisciplinary teams to refer to. So some goals came out of that around increasing statistics, establishing standards, placing an increased emphasis in rehabilitation in cancer care. And I suppose to address some of these issues in particular, we wrote a grant for the PERCS project. Now, to give a little bit of context as to the situation that PERCS came, or the opportunity that was presented to us here. So PERCS was developed in response to a grant call that came out from the Irish Cancer Society in the middle of the COVID-19 pandemic. And the purpose of the grant was to try and address the deficits that patients who were treated during COVID-19 naturally experienced, because services had to, you know, shut down, prioritize, you know, keep people away. So I suppose that's the context that PERCS was in. We needed to have a method of getting patients to services quickly and in a way that was needs-based to address this backlog. So, but we also wanted a bigger vision with PERCS as well. It's like, well, how can this help us into the future? How could this help some of the issues that Gráinne is experiencing? So with PERCS, we aimed to create a sustainable, replicable, scalable model of rehabilitation for cancer survivors. How did we ensure that patients are directed to the right service for their level of need? And we wanted to link acute services to community services. So we wanted better referral pathways and integrated rehab from diagnosis to treatment. So these are the concepts that underpin what we wanted to do with PERCS. And we had two main work packages with PERCS. Firstly, we wanted to create a website, and secondly, we wanted to create and test a triage and referral system. So the website first, this is our website, it's cancerrehabilitation.ie. And this was a really important piece, because that knowledge piece that physios spoke about, and that ability to refer, the referral pathways, a lot of that is underpinned by not knowing what services are out there. So we did a huge amount of co-design work with patients and with stakeholders and health professionals working in this space. We wanted to create a space where there was accessible information for patients, so they knew that they should be talking about exercise in oncology. But really critically, we wanted to create this service directory. And you see the map of Ireland here and all the services that we have mapped. These are not all physiotherapy services. Some are community rehab services that are offered by a range of different professions. But we wanted to create a community. We knew that we had a certain amount of services in Ireland, but really to scale up and expand, we need to know where those services are, what it is they offer, and create better networking and better communication between everyone that's working in this space so that we can actually refer to each other. We also included some videos that Grania had created previously so people could log on to our website, and if they couldn't access services locally, at least we had a little bit here that we could supply to them. So this was our website, and that really was a foundation piece for what came next. And what came next was our triage and referral piece. So we really tried to make this triage algorithm, or I suppose pathway, framework, whatever we want to call it, as pragmatic as possible. We looked at the evidence. We said, right, well, what are the key things that determine where somebody needs to go? And we looked at it clinically, pragmatically. We sat down with Grania. We said, like, what are the big things that you see with your patients that are coming through? So, you know, Grania is seeing about 500 patients a year are referred in through her. So there's a huge bed of knowledge there. So we wanted to include an assessment. Here we have a physiotherapy-led assessment with background, comorbidities, and establish if somebody needed pre-screening prior to exercise participation. And then we had, I suppose, a triage piece that involved two key questions. One, is the person already meeting their physical activity guidelines? Are they already active? Are they already doing okay? And they really just need a bit of reassurance. If they answer yes to that question, we give them advice. We advise them to continue with their current level of physical activity, and we direct them back to our website, which we know contains lots of accessible information for them. And they can always contact us and, you know, make contact again. But these are a lot of people who just need reassurance that everything they're doing is fine. If they answer no to that, well, we know they might need a little bit more support to become physically active. The next big question is, well, do they need to be in an acute, medically supervised physical activity program, or can we link these people out to the community? And I suppose we underpinned that by the questions around significant comorbidities, which we mapped back to the NCCN criteria, their falls risk, so we did timed up and go, and their performance status and ECOG. And we very pragmatically said, look, if they're clear in all of those, we can link them out to community services. And if they're flagging on any of those, we want them prioritized for acute services. That's how we mapped it out. And we developed a personalized physical activity plan with goal setting. And we used our website then to link people back to a service that was geographically close to them and that was suitable for their level of need. So, as I said, this was funded in response to COVID-19. So we ran this as a research piece. We had to recruit people who had been treated during COVID. So we had to go back, not on a referral basis or in a clinic basis, but we had to send out letters and invite people to participate. So we recruited 64 patients over 5 months, which was a recruitment rate of 25%, but quite a speedy recruitment rate as well. Mainly female, around 61 years of age. And all patients who came to us accepted an exercise referral. So everybody who said, yes, I'm going to participate in Perks, they went on and they followed the triage system that we had in place for them. And then 72% of our cohort returned for a 12-week assessment. And really here, we just wanted to see how they were getting on. In reality, in a real world setting, this return visit may not be needed if they are referred out to an appropriate pathway that they're linked in with. But I suppose we were just interested in collecting this data. So it's quite a high return for a lot of people who had actually said, you know, you're doing fine, keep going. So interestingly, a lot of these patients were about 2 years post-diagnosis and post-finishing treatment, and 90% of them required either level 2 or level 3 support. We had an appropriate onward referral option across the country for everybody. Only one participant. So when we triage people, we rang them a week later and we said, well, how are you getting on? Are you happy? Are you linked in? Do you feel safe? Do you feel you're in the right level? And only one person out of the 64 that we triaged, we re-triaged, and we brought her from a level 2 up to a level 1. And that was that was the only one time. 5 people required medical pre-clearance, which we were able to give, and 1 person, sorry, I've already that in. We did pay for all of the services that people engaged in. One, I suppose, issue that we have in Ireland is that a lot of the services that you see mapped in our map, patients do need to pay for them. So as part of the research piece, we covered that cost, but if patients were being asked to cover that cost, the cost to them would be €107 over 12 weeks, which isn't a huge amount, you know, in context, but for an individual, it may be out of reach, particularly if we're looking at underserved groups. We did send the majority of people to community services, and that's, I suppose, what we wanted. These people were 2 years out. We wanted to make sure that those who needed specialist services were able to access them. And I suppose the whole point here is that we're addressing things like waiting lists by identifying those with complex needs and making sure that they get to physio, get to rehab. Impact then at T1, well, I mean, it was, and you know, this is a single arm design, so we keep that in mind. But like the number of people adhering to strength training guidelines after, you know, quite a hands-off program, it tripled and almost doubled for adherence to aerobic exercise. Like that's enormous for one specialist triage appointment and then referring people out to where they need to be. We also saw improvements in things like hand grip strength, sit to stand, 6-minute walk test, etc. And what do people tell us? Well, I suppose they really saw that Perks filled a gap. There was an unmet need, and Perks was very, very suitable for filling that need. They liked that it was tailored. You're going to need this. This is going to be really good for you. I appreciated that. They realized that they got into bad habits after their cancer diagnosis and never got going again. And this kind of rescued the situation. And one person described it as an 80% improvement in their health and mindset. So, you know, from the one triage assessment. Really, really important to us was that we created more community around Ireland, that we tried to bring people together. We'd lots of good people working in lots of different professions and roles across Ireland. And we need to kind of start working together a little bit more. So we did have a networking day, and you can see here it was mainly physiotherapists attended, but we had lots of other attendants as well. And we did lots of interdisciplinary working. We had lots of discussion outputs from that as well, looking at barriers to service delivery. And a lot of it comes back to what we saw before around awareness and travel burden. Workforce education and training needs came up, and lots of solutions for a better future. Coordination and networking, community involvement, patient involvement. We had a lot of patient involvement here, and it makes a world of a difference. So what next for Perks? Well, next for Perks, I'm delighted to be able to say, is that we're going to be looking at, well, how do we nationally implement it? We're going to be looking not in a kind of hands-on patient-facing way, but through implementation science. We're going to engage with lots of different stakeholders around the country and think about, right, well, what are the barriers to implementing something like Perks, map them to implementation strategies and come up with an evidence-informed implementation plan. We're also going to look at cost. How do we upscale? What is it going to cost? And what would the cost benefit likely be to our patients? So we have a lot more work to do in this space. So thank you very much. I think I've just come on to my 15 minutes now, and check out our website for further information. So thanks a million.
Thank you very much, Emma. That was great. Thank you for presenting. And now it's your turn, Ilan, to present your program in Israel. Thank you.
Okay, you can see. Yeah, okay. So, hello, everyone. I'm excited to be here. Thank you, Elena, that you invited me today. I'm Ilan Tausig, I'm a physical therapist, and I'm lead the oncology physiotherapist team at IPT-HOPE Hospital, Tel Aviv. IPT-HOPE is one of the biggest hospitals in Israel, and in the last few years, we developed a few exercise programs for the oncology patient. So first, what we have in the hospital, we have the usually treatment in the oncology and hematologic unit. we are doing consulting at the outpatient daycare. The physio come there twice a week. They get a list of the new patient that arrived, or those who want to see us. And mostly we're doing consulting on the important to be active and exercising during the treatments. In the end of the consulting, the patient get a letter with our recommendation. We're doing cooperation with different units at the hospital. For example, with the nutritionists that send us patient with low muscle mass and with sarcopenia, and we're doing the opposite. And with the surgeon that send patient for rehabilitation before majority surgeries. And we are meeting in the end the patient in the physiotherapy clinic. So what we are trying to do at the clinic is to accompany the patient through his journey and to be for him at the critical points as the rehabilitation during the treatment, after the treatment and the survivorships, and of course, if they have advanced disease. So we are offering a few options for that. So first is the follow-up. It's for those patients that can come to us oftenly. So when they come to the hospital to different things, we are meeting them. And mostly we are just update their exercise program. We recently started online treatment for those patients that can come to the hospital because they're healthy, like after allogenic bone marrow transplant, because they're low immune system, or because they live far. We are doing a intake, online intake, and we are building a program. And after we are just update and follow up their online. We have one-on-one treatment for those who with low physical function, low disability, or those who need more attention from us. And we have the group. Our group program called Open Door Program. It's happened 3 times a week. It's 1 hour of activity that we are closing our gym just for those patients. The patient choose when he want to come during the week. We trying to be flexible as we can with those patients. So we just need to open the door and start to exercise. In the group, there are heterogenic status of the disease, which means they can be in any point on their journey and different age. Like in this photo, the youngest one is 28 and the oldest is almost 80. And everyone doing according their ability. It's hybrid, which means it starts with a group session, and after it's personalized, the physio writing for each person a program for his goals and for his needs. And in the end, I think the important one, it's our volunteers. It's called patient-led rehabilitation. Our volunteers are survivors, and they guide the group with the physio, and they give for those patients more hope, enthusiasm, and another perspective on their rehabilitation. And we have a hydrotherapy pool. It's actually exercising at water. It's the same idea of the open door that I mentioned before. The interesting part here is that it came from the patient, from their experience at water. They came to us and asked if we can open for them groups at the water. Today is a big success, and it's give for those patients another option to exercise during the week. And our last program, it's a survivors program. It's with multidisciplinary team that include a physician, nurse, nutritionist, psychologists, and of course, a physiotherapist. It's 4 months program. They can twice a week for 45 minutes of activity as a group. And after they have meetings with the other disciplines, they get literatures related to survivors in different topics. And in the end, some of them continue to our physiotherapy clinic to continue to exercise. Thank you.
Excellent. Thank you very much, Ilan. That was a great presentation of your program. And we would like to thank, first of all the speakers for their wonderful presentations. And this is really a great time for questions. So somebody who wants to open their videos, they can write the questions on the chat, or they can just, open their mic and ask the questions. This is a really good opportunity. Here, Caroline is thanking for the excellent presentations, and I agree. I learned a lot today myself regarding the programs, the different programs. I think this is really where we need to step up to provide better programs for our patients. If we want to expand our, our services, this is the way to go. So let's see. So far, do we have any questions?
I've
Okay.
got a question if no one else has a
Yes,
question to start
absolutely.
off with.
Yes.
Ilan, I'm really curious to hear more about the volunteer-led exercise. Volunteers is something that we've talked a little bit about here in Australia, but there's lots of, I suppose, governance and, concerns about having ex-patients running things and stuff like that. So can you tell us a little bit more about how consumers sign up to lead the group and what training they are provided with and how that runs a little bit more?
So their experience that of our volunteers is that actually they are survivors, and they be in the same situation like the patient. So this is the only experience that they have. But the important here is that they are sharing with the patient their experience on the journey of the illness and on their rehabilitation. The first patient that started in our clinic today, she is our volunteers. So she started to exercise, and she get her experience from there, and she started to volunteers in our clinic. And like I said, they are they help us to organize the group. She came before the group. She are we have folders with each program for each patient, and she are helped me to organize that. And after she are guiding the group part, and after that in the personalized when we are starting the personalized program, she is with me or with the other physio and help us with the patients.
Yeah, so it's still physio-led, but you have volunteers help
with the
patients
physio is always lead.
Yeah,
of course, the physio always lead the group.
Yeah. Thanks.
Thank you, Amy. You can definitely ask your question. Please go ahead.
Thank you, speakers. That was excellent. Accompanying in the background, apologies. I suppose I have two questions. My first question is, I noticed where that you had 5 required pre-clearance. I'm just wondering how people, so what I feel is people in community, they're exercising. Do we need to go back and get clearance for them medically to exercise? Giving people autonomy to go ahead and exercise, but do we need clearance ourselves? Do we need to go back to the GP, the oncologist? Or do we accept that we're in a community and people need to learn to make decisions about their own physical activity going forward? I suppose that's my first question. My second question is that I find the biggest battle is getting people to engage in physical activity. So how do we get them then to start hitting the guidelines, and even then getting involved in physical activity is a big enough challenge? How do we keep that continuum to keep long-term sustainable physical activity with people? If those questions make sense.
Thanks, Amy. Two hard questions. Thanks a million. So to your first one, look, we used the ACSM pre-screening algorithm, which meant that we didn't have to get pre-screening or didn't have to get medical clearance for the majority of people that went through. And we agree with you. We don't, it should be a thing that, that people are taking responsibility and that we don't overly medicalize it in that sense. But having said that, we are professionals. This was a physiotherapy-led program, and we did feel that it was important, to have that screening there. It was quite easy because we were within the hospital system to get clearance on the 5 people that were needed. I mean, I think we had it within a few days. So it was fine, but we did just do that screen just, I suppose, to be able to say, no, you don't need medical clearance, more so than anything else. And we would typically do that across a lot of what we do. Now, we're mainly working in an acute sector where maybe people are a bit more, close to their diagnosis or on treatment or, that kind of thing. So, it probably makes sense. Maybe in a community setting, you might do something slightly different, but, I don't think 5 out of 64 was an enormous number, and it was worth the minute or two to do the pre-screen, we felt. How to keep people going, I don't know. I think that's where we need to look at, no patient with cancer is just, only comes with needs in terms of physical or in terms of being physically active. There's so much going on. And physical activity is a complex behavior. It's more than just this is the prescription, you go and do it. We're complex beings and all of that. And there's a role for health psychology there in terms of understanding how we keep people going around, once they start being physically active, should we look more to be underpinning our programs and what we do with health behavior change theory? So, I think maybe the answer lies in there somewhere, but I don't think I have any magic answer to that, unfortunately. So I hope that helps.
Thank you, Emma. Amy, Elon, do you have any suggestions for engaging patients to continue their exercise? I think that's one of the million-dollar questions.
Yeah, I think it's a perennial problem, and like some of the work that I've done has shown that kind of as soon as people stop doing a supervised program, they just kind of stop. And there's a whole multitude of reasons as to why that's the case. And yeah, it's very complex and complex behavior change things as well. I think part of it is having facilities and places that are cheap enough, and then being able to have that peer support. We have had, when I worked clinically, programs in the past where, a bunch of people who were doing a supervised program, they then kind of became friends and started walking regularly around a local park, for example. And actually, there's still, I caught up with someone last year who I saw about 5 years ago, and they still are doing that same catch up. So that peer support element can be really strong, especially when people start together in a supervised program. And then I think as physiotherapists, particularly in undergrad training, I think now it's starting to be incorporated more as part of undergrad programs, using like motivational interviewing and other kinds of health coaching ways of communication that can, I think, help facilitate that behavior change as well. But it's a real challenge. And also to your other point, just relating to getting medical clearance, it's quite explicit in our oncology guidelines that we actually don't want to put up too many blocks to medical clearance. So generally, if people are just starting like a walking program, patients can go ahead and do that without clearance. And there's some very clear guidance in those guidelines and the NCCN guidelines that particularly like people with bony metastases, I can't talk tonight, for example, need medical clearance. And certainly in my experience, the majority of patients don't need medical clearance if they've been assessed by a physiotherapist. And there are some other screening tools that community providers can use. So our Exercise Physiology Association, ESSA, has developed the PARQ, which is a really good screening tool to try and determine whether someone needs medical clearance or not. But certainly in my experience, my general rule is if they have advanced cancer and bony mets, I'm pretty much getting clearance nearly all the time. But for everything else, it's really a kind of a case-by-case basis based on the published recommendations that we currently have.
Very good. We have a couple of questions. There was more of a comment from Angela. Thank you, no questions, but some ideas to take forward to introduce more exercise into my local hospital with limited resources. My only thought was volunteer-led exercise groups, which Amy has just asked and Elon explained. Then sorry, that was more of a remark. Dear Emma, this is from Caroline. Do you have a developed a very nice program for patients in Ireland? However, that wouldn't, do you have any advice to colleagues in, for example, in Nigeria, who do not have a lot of training facilities as much as in Ireland? Oh,
Sorry, that's a good question, Caroline. And I suppose just to caveat that I don't want to speak about what somewhere like Nigeria when I don't have experience, you know what I mean, collaborating with colleagues or understand the landscape, etc. But I suppose one thing that we did in Ireland where we didn't have a training program that we could refer people to, we did go back to kind of telehealth and use some of the videos that we had online, or we found a solution somehow, or we developed walking programs for people, you know, to if they were at level 2. So, you know, I think that is a big challenge. And, you know, a lot of the patients that come to our hospital in St. James's, it's on the eastern coast of Ireland. It will capture people in, you know, maybe higher resource areas as well, even though we do have a big rural catchment. I think that's one of the things that will come up though as we spread across the country and we try to look at implementation in places where there are less resources. So I don't know that I have a good answer for you now, but it's something that we do need to think about.
And I also wonder in countries that have more unique circumstances to being able to deliver rehab, and something that we've got involved a lot with here in Australia, in particularly with both service development and research, is co-design. So working with your patients to come up with solutions that might work for those particular communities as well.
Wonderful. Amy, Caroline also asked a question for you, that you mentioned that Japan was already working on oncology rehab before others were working on it. So what is the reason for that, in your opinion?
That is a very good question. I have not very much of a clue. I wonder, though, whether there is a cultural piece to it in terms of the emphasis that they put on physical activity, although knowing that many Japanese people do have quite sedentary jobs, those who work in office kind of jobs, but certainly kind of having a basic understanding of the culture and less problems with overweight and obesity and things like that. I wonder, I'm only kind of, you know, hypothesizing that physical activity is potentially more ingrained in their everyday life potentially, and certainly things like mindfulness has been around for centuries. So I wonder whether there's a cultural element to it, and they also do have, I think, a very good healthcare system. I'm not exactly sure how their healthcare system works, but I wonder whether a combination of those two perhaps. And they do have an aging population. I think they're one of the oldest, you know, populations, Japan and Korea, in the world, and so have had to be, you know, cancer's been a problem. It's a disease of aging, so for a long time. So perhaps that's another reason why they're on the front foot, because they are definitely a culture that look after their elders, and older people as well. But I don't know. That's just my basic knowledge of Japan.
We might ask them in the conference,
Exactly.
the world conference in May, correct? May 2025. We can ask them directly. You will get some answers. That's a good point. So, Robin, yes, you can go ahead.
Yeah, hi. Thank you everyone for sharing such wonderful knowledge. I'm in Christchurch in New Zealand, and a colleague and I have been working in community, just private practices, doing oncology physio for many years. And during the pandemic, as well, we became increasingly frustrated with the barriers, I guess, to access. And so we ended up creating an online service for people, and it includes all of the healthy habits of education and exercise videos that we've done, and people can follow the 6-week program that we've done, and we're super proud of putting it all together. And it was just really interesting hearing about the data collection, because I think Amy mentioned how good that is to try and collect, and I think it's quite difficult. I think we had to get out of our head a lot being physios and saying everyone needs to have you know, a specific screen and see us, like they have to see us. And actually there's a lot of people that can just benefit from doing exercise at home and do brilliantly. They just need a little bit of guidance and support. And yeah, we've had some really great results from people doing it, our program, which is amazing, but we're not really getting any like firm data from it, which is like great feedback. Yeah, and I just wondered whether you have any recommendations of the types of data. We kind of get them to do a bit of a fitness test at the beginning and at the end, you know, 2-minute step test and some just really basic things, and retest at the end. And it's great seeing that they can improve in that time. Sometimes we run like an online 6-week challenge and we get people accountable like that way. But yeah, if you've got any suggestions of anything.
Yeah, look, I think like the study that referred to that as being a particular facility of the facilitator, jeepers, it's the weekend. It was in a public hospital health service, where, you know, it's really important for us to be able to justify the activity that we're doing to continue to get funding, whereas it's a little bit different in a private setting. But certainly what I've always found really useful is just even simply having stats on your demand and your growth across the years, as well as adherence data, how many people are attending sessions or not. And yeah, just simply having the growth in the numbers, it can be really powerful as well, depending on who your stakeholders are that you want to use that data with. And always having some basic outcome measures. I don't think you need to have a whole gamut of outcome measures, but if you've got a simple quality of life measure, or, you know, some symptom stuff, or a fitness test like you have, just to show that yes, people could improve, can be really powerful, especially like feeding that back to consumers who are involved in these programs and wanting to promote and sell your program more broadly, and having nice infographics to display that data. And then, you know, potentially, depending on what your links are with other hospitals and stuff in the community, you know, you might be collecting stuff about health service utilisation, but that's probably more relevant to those that are in an inpatient setting. But I think the most important is showing the demand for your program, that people actually need this, and they do have problems at the start and they do get better. Yeah, so it doesn't have to be fancy. an online program. You can use red caps and online email surveys and stuff like that. And the consumer data, like just quotes, is really, really powerful. Yeah.
Awesome. Thank you.
Okay, wonderful. Another question from Caroline to Ilan. What are the possibilities in your country for physiotherapists to get educated in oncology in your country?
So we have a great postgraduate course that Elena teach, and mostly we are read and we have a great work group that there we have some literatures. I think that's all.
I think that's great. Yes. Thank you, Ilan. Any other questions before we complete this webinar? So I think this was a really great webinar with a lot of information that will help a lot of physical therapists to know how to start their own program or how to make it better. And then hopefully we'll have more research and more literature to get more information and to really make sure that everybody understands the importance of the exercise in cancer, and that all patients will be referred as part of their cancer care. I think that's the main goal, if I understand. So thank you very much, Amy, Emmer, Ilan, for your presentations, and thank you everybody for joining us today. As I mentioned, this will be recorded and uploaded to our website, to the IPT-HOPE website. So I hope everybody continues to enjoy their weekend, and hope to see you everybody again on our next webinar. Thank you, everybody. Thank you. Have a wonderful weekend.
Bye.
Thank you. Thank you, everybody. Okay.
That was great. Thanks for hosting, Helena.
Yeah,
See you
thank
later.
you. Bye, Amy. Enjoy your weekend. Thank you. Okay.